This week on the Backtable podcast.
As the RFS annual meeting chair this past year, we did like a roundtable with chief residents, and it was both incoming chief residents and outgoing chief residents. And what's happening right now in IR is it's still a very young residency program. And what we'll see is sort of fine tuning of some of these things over time. Obviously, there are regulatory boards to kind of please with many of these, changes to the rotations and to different requirements. And so that takes time, but then also feedback from senior trainees like us, I think is what's going to push this forward.
My name is Neil Jain, and I'm a integrated IR resident over at Georgetown, and I'll be your host for today's episode, which is optimizing the integrated IR-DR curriculum and the experience. I have two wonderful guests here, Dr. Nicole Lamparello and Dr. Gregg Khodorov. And before we get started, let's just kind of do some introductions. We'll start with you, Nicole. Why don't you just tell us where you're from and what your role will be here today?
Sure. Thanks, Neil, for having me on Backtable. So I'm Nicole Lamparello. I'm an assistant professor of clinical radiology at Cornell in New York City. I'm originally from New Jersey. I completed my fellowship in 2018 at University of Pennsylvania. And before that, I was a resident before the integrated residency program. So I was a regular diagnostic radiology resident at NYU. And I also completed medical school at NYU and also the program director at Weill Cornell Medicine for the integrated residency program and also the independent residency program for the last 4 or 5 years. And I've been really involved in the whole education team since I came to Cornell.
Great. We're excited to kind of have your viewpoint today and how we can make our curriculum experience better. And Gregg, why don't you give us a quick intro as well?
Sure. So my name is Gregg Khodorov. I am a PGY5 entering my PGY6 year at Thomas Jefferson University Hospital in the integrated IR track. Before med school, I went to business school, so I got my MBA. So I have kind of a unique perspective from that standpoint. Born and raised in New Jersey, so East Coaster for now. We'll see where life takes me next. I think, Neil, it's worth mentioning that you and I go back to like the first moments we discovered we wanted to go into IR as medical students.
Yeah.
The origin story, the lore.
Yeah, I love that we have the New Jersey crew here today. So I know both of you guys from New Jersey IRS and as a medical student. So this is fantastic to have both of you here. So all of us are coming from different institutions and different programs, obviously, Gregg and I are both incoming chiefs, at our respective institutions. And then we have a program director here today. So we've had several discussions at past SIR on how we can optimize the integrated IR-DR curriculum. So our agenda today is we're going to break down each single year or a category of years and then kind of go from there. So let's start off with PGY1, the formative years, the first doctoring years as they call it. What is the optimal rotation or the optimal category that you should choose? Should it be a medicine year, transitional year, or a surgery year? And how does that impact the IR training? Nicole, we'll start with you.
Sure. So I guess I'll start with how we have been doing it at Cornell, which I really like. So our intern year, which is a surgical year, is linked with our residency program. So when you apply through the match, you match for both. So it'll be a 1-year surgical intern year. I think that's a really big benefit because when you're an intern, you are working with your co-interns who become the surgical chiefs when you're in your senior IR training years. So I think you have this really deep connection with them. You've been in the trenches with them. You know them really personally. And that makes for a good relationship when you're fielding consults during those final IR years. You also get to really know the surgeons and they know you. You've scrubbed with them. You know the different cases they do, how they like to manage any like patients or complications. So I just think those relationships become very important. And then I also think it just gives you a little bit of a leg up when you are already at the program and you know the way the workflow is, you know the medical record system, and you're just a little more comfortable when you're coming into your PGY 2-year. But I do think there's a lot of potential for how that year is designed. Our residents spend 6 weeks on interventional radiology when they're surgical interns. They also do rotations in the surgical ICU, trauma, vascular surgery, up to maybe 8 weeks in vascular surgery. And we every year are going over how to really tweak the rotation so that it could be better suited for their career in interventional radiology. But there's a lot more to do. I think there could be really great value in having them rotate with GI and do see the scopes or interventional pulm, transplant. So I'd really be interested to see what you guys think, since you can see what kind of rotation or intern year you guys did.
Yeah, absolutely. It seems like Cornell has a very similar program setup as we do. We also have a categorical year with similar rotations. I think our program also added the transplant rotation, trauma, vascular surgery, and then we get 2 months of IR, which is great. Kind of makes you feel part of the IR family during that grueling first year. That's great to hear. How about you, Gregg? How does it work at Jefferson?
Yeah, so Jefferson's a little different in the sense that we don't have a categorical track. We have an optional preliminary linkage. So if you want to do your prelim year in general surgery at Jefferson and you match at Jefferson for IR, you don't have to interview again. You just auto-matriculate into the surgery prelim year. So it's a good option for people who want to, like myself, I was couples matching. My wife was going into internal medicine. So moving once in 1 year and just having all your training at one institution, in addition to all of the sort of the benefits of being a surgical intern, like Nicole mentioned, the benefits of just kind of moving once, I think are pretty tremendous. But then it gives the flexibility for those trainees who, are in the reverse situation where maybe they're waiting for someone else to finish up their training for another year, or they want to take one more year of, at their home institution or near their home or something like that before they move. So they can do their preliminary year elsewhere. So I did my general surgery intern year at Jefferson, but my co-IR integrated resident, Charles, did his intern year in medicine elsewhere. So it's been interesting to see, as we've entered now into our PGY 5 years, I think some of those sort of intangible differences have kind of, or not intangible, but sort of those softer differences between doing a surgery prelim year and a medicine prelim year have kind of gone to the background. I don't feel as strongly anymore that we have a noticeable difference in our training. Whereas in our R1 year, I was very familiar with kind of the Jefferson system and the surgical residents and how the surgical services all work. And Charles had a little more catching up to do. So I agree. I think there's definitely some benefit to doing your training at your home institution. I've built lifelong friends in the surgical program, and they are going to be the chiefs as I am a chief. So in that sense, obviously, it makes for, a little more collegiality across specialties and a little more empathy. I think they understand kind of what we go through and vice versa. The other thing we just introduced is in that preliminary surgical year for our integrated residents, we do give them now 2 weeks of interventional radiology, which was not the case before. We were just purely surgical residents interacting with IR only as a consulting service. But that was something we fought pretty hard for, just to get both for morale reasons. I think it's really important to kind of remember what you signed up for. And if you go a full year without IR, and then let's say your IR month is not until the end of your R1 year, you're going 2 full years without doing what you signed up for, what you love and what you're interested in. So from a morale standpoint, I think it's really important that we reintroduce that. And also from and I think we'll get into this a little bit later, but from a preservation of culture and integration into the kind of the department, prevention of attrition from the program, I think it's important to kind of remind the junior trainees what they're signing up for and where they belong, where home is.
Yeah, that's great. So I think from what I'm hearing, surgical years are great. It seems that, again, it builds a sense of culture with the consultants that you're soon going to be working with, especially during your more fellow years, PGY 5, PGY 6, especially since a lot of them do stay around. So what would you recommend for medical students or now interns if they're in a medicine year or transitional year? They do have some electives. Do you recommend for them to have electives in maybe GI or hepatology? Because those would be something that, that they would be able to do during their medicine years. Or are there other rotations that you recommend?
Yeah. So I think that if they have electives, I think those are great choices to consider. I did a medicine year, and I guess I would say to those students or interns, like, don't worry. As Gregg said, like, you will catch up though. And I don't feel really that I am behind because I didn't do a surgical year. I just think it might have made the beginning a little easier, having maybe seen different surgeries and scrubbed in and knew the anatomy of the different surgeries. I think really just like take advantage of what you're learning. Like now you're learning a lot about like the medicine and like the dosing of the antibiotics and how to treat that, like a hypertensive crisis. Like just you're going to have other skill sets from that medicine year or transitional year. So just use that to your benefit because that'll be useful as well. But if you do have the option for any kind of electives, I think GI would be great and hepatology for sure. We have our senior integrated residents do a hepatology rotation. So I think that's tremendous. And also, I guess I was curious from Gregg's perspective. So you said your year, one of you did the opted out and one opted in into that Jefferson surgical year. What has it been like in the past? Is that sort of the standard, like 50-50, or do most residents try to?
It's a little more than 50-50. I would say most residents opt into the surgical prelim year.
Mm-hmm.
Our program kind of both officially and unofficially recommends it. And I think also just from a cultural standpoint, the speed with which you gain autonomy in your junior years rotating on IR is faster if you did a surgical intern year. I think part of that is just kind of comfort with the, procedural aspect of interventional radiology. So from that standpoint, just like working with your hands and performing procedures, placing lots of lines in the SICU as an intern, those skills come back.
And if you're in a
quickly.
medicine year, I think you can like try to like join the, if they have a bedside medicine procedural service, or try to do all the paras and the non-tunnel lines. Yeah, try to teach as much as you can. So I think whichever route you take, you can try to make it work for you the best you can.
Yeah. I was going to say, the other thing that you kind of mentioned, sort of like hypertensive crisis and, diabetes management and all those things, obviously critical. You will obviously for the medical students who maybe are not so sure, you will get, a lot of that in your surgical prelim year as well. Like obviously you're managing pre and post surgical patients, and they have all sorts of medical issues going on with them. And most surgery services operate as a primary team. So you're managing all of that. And then obviously consulting internal medicine when needed. But I will say, like, even having said that, I just, did that PGY5 hepatology rotation, and I could not believe how much of medicine I had either forgotten or hadn't seen since medical school. So there's lots to be learned from either pathway. I think generally the sort of consensus is that the overlap is probably a little higher with the surgery intern year in terms of transferable skills and knowledge, but both will give you a great basis. And honestly, both are really important for your diagnostic radiology years too. Like either or will give you a unique perspective. I think even in that case, the surgical year adds benefits in terms of understanding cross-sectional anatomy. You're obviously in the OR performing laparotomies, seeing where the liver is, where the spleen is, where all of this different anatomy is, and battling with that every day and trying to get better at it. And then the other thing surgeons are very good at is looking at their own imaging. So in your intern year, you will be looking at the CAT scans your patients are getting as they're getting passed through the ER, as they're getting post-operative complications. Whereas I remember my wife as like a PGY3 medicine resident admitting to me that she like barely ever actually looked at the images and mostly looked at reports. And I was like, my heart just like broke. But the reality is there's so much to battle with in medicine, and you're taking care of a large patient census. Usually you're taking care of very complex patients with many comorbidities and diseases. And imaging is only like a very small part of the whole picture for an internal medicine resident. So spending your time, going back and forth through a CAT scan may sometimes not be worth it. Whereas as a surgery resident, when you have to decide whether or not a patient goes to the operating room, and if so, what kind of operation they're going to get, anatomical landmarks really matter. So I found that I was looking at cross-sectional imaging quite frequently as an intern. And then when I hit my R1 year, I was sort of ahead of the medicine and transitional year prelim radiology residents that were in my class.
Great. I'm glad that Andy was at least reading the reports. They usually just jump to the Spark Notes or the impressions version.
Yeah. I think it was a moment of honesty that she wishes she could take back, because I've never let her live it down.
Well, I think this is a great segue to the diagnostic years, PGY2 to PGY4 years. Often residents are now transitioning from a brutal surgical medicine transitional year, and they're going and learning an entire new language. And often residents start feeling like, hey, this is also not what I signed up for. I signed up for IR. They feel benched, as like quote unquote, from what I hear. And they just want to be put in the IR suite. So let's kind of go piece by piece. First, what is the optimal number of IR months during those DR years? Gregg, we'll start with you. How does it work at your program, and what are your thoughts on the number of years?
From our PGY2 to PGY4 years, we're indistinguishable from the diagnostic residents in terms of the amount of IR we get. So we get 1 month a year. I know many programs are starting to lean more on 2 months a year. I know at the higher end, there are some programs that are like 4 months a year. I will say that I think that there's probably some value to getting a little bit more than a month a year in those early years. One of the frustrations I had was just kind of like, it takes about a month to get comfortable doing many of the procedures we do in IR, especially the basic ones. Understanding their indications, remembering, what the difference is between a tunneled PICC and a tunneled hemodialysis catheter, and, all of those little nuances that you kind of like when you're not on IR and you're in your radiology months, you just completely forget about. And then you come back and you're like, oh, shoot, like what are these things again? And how do they work? And what are our institution's strange indications for each of these? And all of those different little minutia. And I've always found that like by week 4 is when I'm finally feeling comfortable again. And then they're like, all right, see you in a year. Yeah. So I feel like there's some value in maybe getting a little bit more consecutive training. I did have 1 year where I had the last month of my R2 year and the first month of my R3 year were both IR. And I loved it. I loved that I had 2 months straight, but I could really like hone my skills in that second month. And I'd kind of gotten over that like, beginner's hump before finishing my rotation. So the trade-off obviously is, you don't want to sacrifice good diagnostic training. At our core, we're still very much image guided, an image-based specialty. So if it means, cutting out something that like potentially is important to both you passing the core exam and your diagnostic boards and also like just gaining enough case volume to really feel comfortable with diagnostic radiology, then I think the sacrifice is not worth it in that case. So you really have to be careful when crafting this sort of thing. I'd be curious to hear, Neil. I think you guys have, what's your setup?
Sure. We also have just 1 month for the diagnostic years. So it's very similar to you. You're pretty much like a DR resident. It's more of like the integrated journal clubs and lectures, which we'll talk about in a bit. But yeah, diagnostics is so important. We often hear this phrase that to be a good IR, you need to be a fantastic DR. So I wouldn't want, to lose any of that training as well. So Nicole, how do you see this from the program director side? Like, you've had many residents come through your office and.
Yeah, I mean, exactly what Gregg was describing is what I've seen, where I think there's a lot of pressure for the integrated resident, because usually during those PGY 2 to 4 years, you are treated like or you have the same exposure to IR, just like the DR residents. You come 1 month a year, but since you're an integrated resident, you think, or maybe it is, but that people view that you as you should already know this, or you should already be able to do this because you're an integrated resident. But the reality is you might have not had as more experience than the DR resident that you're next to. So that could be a lot of pressure. And sometimes even if you had, Greg, like a rotation at the end of one year IR and then the beginning of another year, that means then maybe the following time you have IR is an even bigger gap, right? So you could be getting almost a year between rotations and then might have to feel like you have to catch up and relearn things. So we've felt the same thing and heard the same kind of feedback from the residents at Cornell. So starting next year, we're doing something different where we're giving the residents a little bit more IR, probably, I think, 2 weeks over the course of their whole year, their whole residency, 2 weeks more. But we're also shifting rotations a lot. So our R1s would get 2 weeks of mammography, which they thought was like sort of useless in their R1 year when they're really just trying to learn the basics of radiology. And so we took those 2 weeks and we're making those IR weeks for the integrated residents. And they'll have to complete those mammo weeks later, but it'll be in their probably last year of training. So we're shifting a little bit of the way the rotations are going so that we can front load IR a little earlier. So I believe our R1s are now going to have 7 weeks of IR, and we're going to split that into groups of 4 weeks and 3 weeks so that they can sort of get a little bit of IR throughout the year so they don't have those large gaps where they're not in the procedural suite. So we're hoping that this will help create this continual exposure to IR so that they don't have that like slump through the year. And then we also try to do a lot of other events throughout the year to keep them like part of the IR family. We do quarterly simulation events where we bring them to our like simulation center that we have on site. And we try to really tailor these more for junior residents. So the last one we did was about biopsies and just going over like all the equipment, the different sizes, about gel foaming the track, like a lot of basic things, but just so that when they went into a case, they just felt like they knew everything about that. And we're going to do one soon about vascular access and closure devices. So we're just trying to create very targeted simulation events to the junior residents. In addition to, we do a lot of like social events throughout the year, just with we have these mentor groups. We have each resident year like in a family. So a PGY 2, 3, 4, 5, 6, and then an attending. And they're sort of like in this pairing. And that allows someone if you're in that family, you can have someone at each year of the residency to mentor and then also to ask for advice. And then the groups do different social gatherings together and we have like little competitions, and it's just like a way to keep each other involved throughout the years.
I really like that idea.
Yeah, we call it like a men-tier program, and we actually like wrote or published about it in the last year or two. But it's a nice way because every year training is different. So if you're starting the program, it's nice to be paired with someone in every year just so you could see how they're doing.
Particularly for a larger because Cornell has four residents a year.
We have 3. It's
3.
Yeah, only just 3.
I think that's a great way of just integrating them early. How about for ESIR residents, are they kind of built in the mix, or if they're thinking about pursuing ESIR?
So they're completely in the mix. If we get an ESIR or an independent resident, we just plug them in and they're treated identical as if they were an integrated resident. So we make no distinction with that. And then if we have any residents that are DR and they're interested, or they have like this inkling that they like IR, we invite them to all these events and bring them to the simulation event. We try to
reel them in.
Give them a couple of rep dinners and send them on their way.
That's great. I think there's large push to increase IR exposure early on. Again, at our program, like I mentioned, we have 1 month of IR every year. Additional ways that we feel integrated is that we have educational activities such as lectures. We have something called Sabri rounds, which are every Tuesday, and they'll be at 7:00 before the DR lecture. So everyone can participate as well. We'll have journal clubs. We have M&M interesting case conferences as well. So I think those are great ways that we can kind of feel like we're still learning IR while we're on DR as well. There's one thought that we're trying to, we're flirting with the idea of potentially maybe even do like a half-day clinic a month or so. Again, it kind of makes you like, not lose all of your clinical skills when you're in your DR years. But these are maybe some like avenues that, you're still part of the family.
We last year we implemented clinic for our junior residents, and with the help of our chief residents, we identified the different diagnostic rotations that they could be pulled from without affecting the rotation or the work on other residents. And so before one of the integrated residents has that rotation, they get an email from our chief, like, you've been identified that you're on a rotation, that you're allowed to come to half-day IR clinic. Like, do you want to do this? And so we give them the option. So we started that this year. We haven't had that many people who want to come to clinic, but we do offer that as another way to keep them engaged.
Yeah, we also just in the last year or so introduced structured once a month half day of clinic for all junior integrated residents. And that, I believe, gets put on pause when you're studying for core, like in that last half a year of your R3 year. But other than that, that's a new requirement that we've been pushing for several years. Because, when you're a senior resident, the ultimate conundrum is when you're a senior resident, you're too important to the procedural sort of flow to be pulled out for a clinic day. And when you're a junior resident, you're on your DR rotations and it's hard to find the time. So I think this is a good balance. Obviously, we still get some clinic days as senior, like PGY5, PGY6 year, but this is a good way to kind of introduce you to all of those aspects that you may not think about in terms of IR. Like, what I'm finding is every time I go to clinic, so right now I've been rotating, I made a 2-week interventional pain elective. So I've been rotating with some of our anesthesiologists who do lots of our pain procedures here at Jefferson. And I'm learning from their clinic, like managing opioids and refills of those prescriptions of pain meds and, all of those different aspects that you kind of just forget that we have to deal with when we get out into practice, especially if you're going to be practicing, true clinical interventional radiology.
That's very neat. Yeah. So for us, we have a half day clinic if you're PGY 5 and 6, every single week you're on IR, you have a half day clinic. And then if you're a junior resident, whenever you're on your IR months, you have to go half day clinic. And this applies to everyone from PGY 1 to PGY 6. So yes, I agree that sometimes when you're a little bit more in your senior, when you're at the senior level, you may not want to leave, the IR suites, but I think our program has done a good job of kind of making IR clinic important and kind of essential to our learning. And I think this is a great segue to consult service. I'm very curious to hear what the structure is at your guys' institution. How it works for us is we, as a junior resident, when you start off as a PGY1, since it's a categorical surgical program and we have 2 months of IR, we have a week of clinic at a time. And that's from PGY1 to PGY4. And then PGY5 and 6, you won't have any consult weeks, but we do them at a week at a time. For us, it seems like it's been working pretty well. Like you get to you get a lot of consults early on in the week and, you get to provide that longitudinal care and to make sure that none of that falls through. But how does it work at your institution, Gregg?
So for us, it's a daily rotation. So you just kind of rotate through all of our rooms, our biopsy service. And then one of those days of rotation is consult. We call it out doc because you're out of the procedure room. So when you're out doc, you are working with the on-call attending for the day, who also rotates every day. So one thing that I've been thinking a lot about is sort of like the continuity of care that we end up delivering with this system. I mean, we have good handoffs. Obviously, we sign things out that need to be signed out. And the resident who is out doc one day is still on service the next day and at round, so can kind of answer any questions from that day. I think there's definitely value to like a longer sort of like a week of consults, perhaps, with the same attending. I know that's kind of the Cornell model. So Nicole, I'll let you talk about that. But yeah, I will say that like generally it works pretty well. It prevents burnout. I think being at a busy hospital with lots of consultations, it can be rather busy. And it can also be a little demoralizing at times. So kind of shifting that burden every day to somebody new it just keeps everyone kind of fresh and and everyone kind of, and that goes for when you're a junior resident, you're thrown into that mix. Our DR residents are thrown into that mix, but usually as like a buddy system until they're kind of, in their second or third week of their rotation. And then even our PGY6s will continue to see consults on that sort of like probably like every 7th or 8th day. They're the consult doc. So in that sense, I do appreciate it, because even now I'm like learning so much from those consults. And I think there are things that when you're a junior resident, you don't even know to appreciate about, like for instance, when I was a junior resident, in my head, a G tube was appropriate if the indication was there, right? But then you slowly realize like, oh, I actually need to have a window in order to place a G tube. I have to review the imaging, like all of those things that are just, and that's obviously a simple example, but the more complex the procedure, the more complex kind of the workup. So I think there's some value to taking consults throughout your training, especially if you're planning on practicing in a community setting where you're likely to, be taking those consults as a junior attending. So I don't mind that, but I do think maybe some more continuity would be nice. I think for us, it's mostly a logistical issue, a little complex, and I can't fully wrap my head around what the barriers are, but I know that like there's an internal desire to switch to like even more formal like consulting service, one consulting physician who's just, not doing procedures and just seeing consults for a week at a time or something like that. But we've had some like internal, just kind of like systemic barriers to fully implementing that service.
How does it work for you at Cornell, Nicole?
So we implemented a full consult team, or like inpatient, almost IR hospitalist team about 5 years ago. And the reason we did that were what we sort of alluded to, that we thought that would deliver better continuity of care and make us a real presence on the floor, really have more ownership over our patients because the same people were on every day. And so how we do it is a team takes consult for like a week. So the resident, and we have everyone does consults. So the DR residents do it and the IR residents do it. If you're a DR resident or an IR resident on a month IR rotation, you do 2 weeks consults, 2 weeks procedure. And it's a little bit of like a sticking point because consults can be definitely tough. There's DR residents that, though, don't really want to be in the procedure suite, so they actually like consults. But then, at the same time, consults are longer hours often, or could be. So it's challenging, but the team usually has a IR resident, usually an integrated resident, hopefully more of a senior integrated resident, and then 1 or 2 DR residents, usually 2 to 3 nurse practitioners that are wonderful, that are there, that are always on the team. There's 4 of them and they just like rotate, but on any given day we have 2 to 3. And medical students, so rotating medical students. And then 9 months out of the year, we have urology interns that come and stay with us for a month. So they do 2 weeks of consults. And I'm in talks right now with the surgical program director because he wants to send the PGY2 surgical interns, everyone, to IR for 2 weeks. So they'll probably do 1 week of consults also. So it's a big team, but I think the unique thing is that we have an attending that's also on the consult team for the entire week. And I would say in our practice of like 22 attendings, maybe 8 of them do consults because you have to really have a schedule where you're able to devote an entire week in a row to consults. So you can't really have as much, an admin responsibility or a research responsibility. You have to essentially be clinical the entire week. Then that IR resident and the IR attending take the weekend call. So you're really on the whole week and weekend. That IR resident also takes the Monday and Wednesday call. So they're on Monday, Wednesday, Friday, Saturday, Sunday. So it is like a pretty brutal week, but you really know the team. Like we have this, our IR consult list, and you just know them by heart, all the patients, their background. You made a decision for the plan, and then you're there the next day to execute it. The plan doesn't really change. So, and we round on the patients, we go to the bedside, and it's just a night. We've heard from other consulting services that they really appreciate this, that they feel like we're really involved in the care of the patients. And so it's worked for us, but it's a lot because, there's 53 weeks in the year. We need to have an IR resident on every week, right? That's the goal. And so they're doing a good amount of consults. Their PGY 5 year. During their PGY 6 year, they just do 2 weeks, and we make them like the attending week that week. So we try to like have them be the final decision maker on if a case is going to go or not. So we try to give them more autonomy in that respect. Yeah, I mean, I think it's really important because really the decisions that we make as IRs are those things that we learn during the consult weeks. I tell them that you're going to learn the procedural techniques, the catheter skills over the course of your years, your training years. But the things that keep us up at night are deciding, like, is this the right procedure for the patient? How do I manage that complication? That's a real like clinical part of IR that you learn during consults. And I think it's a little hard to understand early on because you just feel like, oh, I want to learn to place this port by myself. I want to do a tips from start to finish myself. But I do hear from our senior residents, like once they're about to graduate, that like they realize like how important those consult weeks were later on, that it did pay off.
Just one other thing I wanted to say is like, the one thing that really struck me, Nicole, about what you're saying is, like you really get to know those patients over the course of the week. And it sounds like the attending doesn't really change for that week either. Is that right?
No, yeah, it's the same attending the whole week. Yeah, and you round twice a day and afternoon rounds. And like we know the patients, just go down the list. And
Yeah. I mean, I think we all recognize that there's inter-attending disagreement from time to time about what's appropriate, what's not, when it's time to take a patient, when, the best thing to do is to just say, there's nothing we can offer. One of the frustrations that I have as a trainee when I'm like, seeing consults and staffing them with an attending one day, and then the next day it's a different consulting resident and a different consulting attending is, like sometimes somebody approves something one day and then the next day it's on our, approved procedure board, and then somebody else takes a look at it and says like, wait, why are we doing this? Like, I don't think this is appropriate. And so there's a little bit of like that inter-attending disagreement, which is, normal. And I think it's good and healthy, but the flip side is it can be a little frustrating when you're communicating with the teams and trying to explain to them why suddenly the plan has changed.
And Nicole, are they doing the procedures as well? Or are the attendings talking to someone else? Like, since they're just the consult attending, are they letting like their colleague know it's like, hey, I improved this is coming down? Like, I just want to know like on the back end how that's working as well.
So there's a lot of communicating. It depends how complex something is. So if it's pretty standard, it'll just get put on the board or put in a room, and we'll talk about that in the morning. If it's any case that needs a conversation, it's you don't know if we should do this bronchial artery embo, then the attendings are having attending discussions, like, or the resident is talking to the attending. But we'll definitely give people a heads up because, to your point, there still could be disagreement or different of opinions on when something can go. But then that consult attending is like the point person. If there's any questions, you come to that person. They're on all week. They know about it. So it puts a lot of work on that consult attending. My busiest, hardest weeks are my consult weeks by far. We do a lot of then just triaging and like workflow and running the board, which we sort of need to step away from a little bit, but they're busy weeks. But I do think it's better for patient care is what I really feel. And I do think that for training, it's giving our residents a really strong clinical foundation and giving them like that decision-making, those skills. So I think that's a plus.
Yeah, that's a very neat framework that you guys have there. So that's something I'm definitely going to bring up to my program. I think it's great to kind of have like a pair, like a duo kind of tackling the entire week. So let's transition to the PGY 5-year and talk about specifically optimizing a couple rotations that a lot of us are kind of in a way mandated to have, which are the nuclear medicine and mammography rotations to get our DR credentialing. So how can we optimize both of these rotations, both nuclear medicine and mammography? Nicole, we can start with you.
Sure. So we're starting a new rotation next year, which is sort of like a molecular interventions rotation. So, and I mentioned a little earlier, we're trying to shift rotations for our residents and have more exposure to integrated IR earlier. And with this is this molecular interventions rotation. So in the PGY 5-year, when residents need to meet their nuclear medicine requirements, we're going to have a 2-week rotation where it's sort of like a hybrid rotation. So the integrated resident will just say like, learn about, they have a Y90 on the schedule. They'll participate in learning about the dosimetry. They'll talk to the nuclear medicine attendings about determining lung shunt fraction. Then they'll come over and they'll scrub into the Y90 and they could accompany the patient and get the spec CT. They could dictate the spec CT. And so they can be part of like the entire care of that patient and be able to participate in the nuclear medicine component, but also the interventional component. And if there's downtime, they're going to read PET CTs to meet their requirements. So it's something that we worked with nuclear medicine on and got their input, and we haven't rolled it out yet. It's just conceptual right now, but we presented it to our program evaluation committee and everyone agreed. So we'll start that soon. And I think it's just a way to be creative for that nuclear medicine requirement, because they could still meet the requirement and be on the nuclear medicine rotation, but also have some kind of interventional exposure as well.
That's very neat. It's great to kind of, learn about dosimetry, learn about a lot of like the nitty gritty stuff of like not just performing the Y90 technically, but all the things that go behind it. So I think that's something we all wish for from a resident standpoint. How about you, Gregg?
Yeah, so the way we handle the mammography requirement is essentially, you really only need that requirement of those 250 mammograms in your last 2 years if you plan on becoming MQSA certified. So it's a resident-driven thing. So if there's a resident desire to be MQSA certified, we can obviously make that work. But, if internally that has not been the case, most residents do not feel strongly about that. Now, granted, the one caveat to that is, obviously, if you are trying to join a breast practice and be their interventionalist, that's something that you need. So we just haven't had any residents really express interest in that. So the way we handle that is you get your, mammography experience in your more junior years. You hit all of your case volume. You just don't get the unless you request it, you won't get those 250 in your last 2 years. And then as far as nuclear medicine, as of right now, I just kind of finished this rotation a couple months ago. You're just a senior nuclear medicine rotator when you're on for that month that's required by the nuclear medicine body. I forget the name of the regulatory body, but essentially what Nicole is describing is, I think, what we're starting to kind of push towards. I independently came up with the idea and then when you first told me about it, I was like, wow, this is like literally exactly what I wanted from my nuclear medicine rotation. But as it stands right now, there's no real infrastructure for that. So I would like to see us move towards a similar thing where, right now, a lot of the dosimetry, a lot of the contouring involved with Y90 happens by attendings between cases. And you have to proactively find that attending and seek them out between cases just to be able to get that learned experience. It's actually logistically quite complex. And, every time I think about doing it, I'm like, oh, I should go, follow this patient and see them. It's too complex. Like the way our schedules work, we don't have the protected time to kind of make that happen. So I think what I'd like to see is like a more formalized Y90 rotation like Nicole is describing. And then obviously, in your downtime, like you said, you can fill that with, standard nuclear medicine learning so that you're still kind of getting some sort of basis. You're still helping with workflows and clearing lists, but the priority is on relevant nuclear medicine to interventional radiology. I felt like a full month of reading PET CTs as a PGY5 who was just like coming off service to do this and then going back on the service was almost like it felt disjointed, and it didn't feel like it was conducive to a senior level IR education, other than it was a very chill month. So I from a wellness standpoint, it was great, but from an educational standpoint, I felt like I was withering away reading PET CTs as a PGY5.
Yeah, I think this new proposed rotation would benefit all of us. It's something we all talk about, that it's kind of, not incorporated in our curriculum. So absolutely. Let's shift finally to the final year of IR, PGY6. There's a lot to be packed into this year. You're almost going to be attending in 12 months. What would you guys like to see? Gregg, we can start with you. There's talks of private practice. Is there enough exposure to private practice during your curriculum early on or afterwards? Is there any talks about private practice? Let me start with that.
Not super officially, but we have been for now several years trying to make it work with one of our community practices, which is run sort of like a private practice would be. Services, two small community hospitals. It's part of the Jefferson system, but the attendings there are primarily just at those two hospitals. They're just kind of working with APPs. They don't have any trainees at the moment. So we've been working on setting up a rotation where we can go out and spend some time with them and just see how the practice varies from our own. I would obviously love to see some private practice exposure built into our training. I think obviously there are logistical challenges to that, especially at a program like ours with 2 integrated residents per year and, lots of cases. The other thing is Jefferson just acquired Einstein, which has their own IR integrated residency. So there've been some preliminary talks, and I think it's going to take a while to really integrate. But there are, sort of things that we do at those two institutions that are slightly different. Like at Jefferson, we have a huge metastatic uveal melanoma practice, for instance, which Einstein does not see a whole lot of. And by the same token, Einstein, their department is run by a neuro-IR. So they do neuro-IR, which is all owned by neurosurgery at Jefferson. So there's some sort of like trade-off and benefit to having those two institutions be under one umbrella, but we have yet to figure out a way to, and that's actually probably the easiest integration because it would just be a 1-for-1 trade of trainees, I think, to make that work. But yeah, there's like logistical barriers to all of this and trying to figure out how the ACGME funding would work and all of that. So these things take time, but those are all sort of preliminary talks at Jefferson. And I expect to see at least that community rotation and the Einstein integration within the next year or two.
So we don't have any away rotation at a private practice, but I think that's like a brilliant idea. And I'm going to sort of start to look into that. We do a private practice panel for the residents where we had about like 5 different physicians from across the country talk about their experience in private practice. Our PGY 6 year is like procedural. So because we're so heavily consult focused early on, that is the year that it's just procedures all the time. And then we give 1 day of clinic per week. So I guess 4 days procedures, 1 day clinic. And the clinic experience rotates to different like sort of subspecialty clinics. So for 2 months, you'll do GU clinic. 2 months, it's sort of fibroid clinic. 2 months, it's hepatobiliary. So it just sort of rotates in different subspecialty areas in IR.
I love that idea, by the way, of having subspecialty clinics kind of grouped for trainees, because when I go to fibroid clinic, a month after I was just in like venous clinic, it's like really hard to kind of like get that consistency and wrap your head around all the learning to be had and
right, 100%.
All the different considerations. Yeah.
It's a little difficult because you sort of need to group the attendings based on subspecialty, but at Cornell, we tend to be a little siloed in that way. And we have these like different niches. So we've just examined the clinic schedule for every provider. And then we'll say, for example, Greg, you're on Friday clinics in September and October. And Friday happens to be fibroid and adenomyosis center clinic day. So that's why for those 2 months, every Friday, you're going to be going and you're going to be rotating with Dr. Schiffman and Dr. Lamparello. And you're going to then really see how they, interview patients. And then by the end, you're doing it on your own. And so it's nice to group it that way. Yeah, so we found it works really well. But we do have, if there's a really big case on that day, it's interchangeable. We've had residents just asked to, take off some time from the clinic so they can go in like a once in a lifetime case and vice versa. We do also have 1 week or 1 month of elective, the PGY 6 year. And usually our residents do neuro-IR or they do interventional pain. But I do think that a private practice rotation would be like a wonderful addition.
That's right. Over at Georgetown and Washington Hospital Center, we're split between both hospitals throughout the year. And then for 1 month, we'll rotate with an interventional cardiologist that does a bunch of complex PAD. So we'll get our training with him, kind of learning the ins and outs. And we are like the primary resident operator with them. And then we also have 2 to 4 weeks with the vascular surgery, and we help kind of run endovascular service as well. And then 2 weeks will be, or I think 1 week at a outpatient dialysis center to do officialograms and kind of learn, how official declots and all of that work on the outpatient side. So I think it's great. I think private practice would definitely kind of complete this picture. Absolutely.
Yeah, and just to echo that, I don't think the benefit of private practice is necessarily like procedural differences, right? Like that's going to change from practice to practice, but just to see how the model runs and when you take sort of the academia out of it all, like how the efficiency matters and patient room turnover and turnaround times and like all of those things and then obviously like in an outpatient private practice setting you'd have exposure to kind of like you don't have an option for a hospital stay the day after a procedure, so figuring out the logistics of that and who's appropriate for that and those things. I think all of that is kind of like I get it in theory, but I haven't seen it in practice, so it's hard to kind of make sense of what that experience would be like. And then obviously not having trainees around, like what that would feel like not being at like a major academic center.
Yeah, absolutely. And I think in that same realm, I think talking about practice building, coding, billing, medical, legal topics. I mean, I'm fortunate that I have John as one of my mentors, and he will often kind of have these pearls that when we're just doing cases or afterwards, he'll just tell you about like, what his approach is. But do you guys have any structured curriculum around this? Any of your institutions, any ways that you kind of help trainees that once they're out, like, they kind of have at least a little bit of knowledge in these areas?
We did start a business curriculum last year with it includes even the DR residents. So it's just a curriculum for all radiology residents, Columbia and Cornell, 8 lectures for the year on those topics that you mentioned.
Yeah, we have a chairman series for all of our radiology residents, and that generally tends to run more on like the business of radiology side of things. And then one of our IR attendings, Rob Ford, runs a like personal finance lecture series, which I also really appreciate. Like things included in that are like, what kind of savings account can you open when your child is born? Things that I've like never thought of before. So just kind of cool to see like what's on the horizon in terms of when you do experience that like salary bump, obviously post training too. And then he also brings in like disability insurance vendors and things like that so that we can sort of preserve our financial health in addition to our personal well-being.
Well, I'll put a quick plug in for 2 recent episodes from Backtable, episode 542, which discusses a little bit about early career in IR and practice building, and as well as a dedicated episode 546 by Dr. Quinn Meisinger about IR practice development, residency to the real world. So I think it's important. I would definitely check those out. And I think we've covered all of the years now. And finally, the last thing I want to talk to you guys about is resident retention and integrated challenges that we're having. There was a study that came out of University of Wisconsin/USC that mentioned from 2017 to 2022, there was an attrition rate of about 3%, with the majority of the attrition coming from R3s, R2s and R3s, R3s being the main culprit in a way of leaving the program. So what can we do better to kind of keep the residents on the IR side and integrate them better? Whether this may be call sizes as well or like a program size.
Yeah, I think this is an important topic. It's something that we heavily discuss at the annual APDIR meetings and something we talk about just at Cornell, because we've had a few residents or a couple of residents leave the integrated program and go to the DR program, but also the reverse. We've had DR residents come to IR. I think it's complex. It's multifactorial. A couple reasons are that for some residents, they might not really, it's different to be a radiology resident than a medical student rotating on radiology. And for a lot of residents, I think that they realize they might like radiology more than they thought they did. Because yes, you're you're sitting at a desk, at a computer, reading studies, but you're now dictating the report and you're taking ownership over your report and you're making the calls. And that might be more attractive than what you thought radiology was when you were a medical student. So some people I think are just realizing they like it and they're finding a field in radiology they like and it's a better fit for them. And then, that's great if that's what works for you. But we also have to take an approach and say, like, what could we do better? Like, what if we changed in the early years, could we prevent this? And for us, we're working to increase that exposure to IR earlier, to keep them involved and part of the IR family, to increase these simulation events and like our mentor and like resident attending faculty, like bonding events, just to let them know like that there is a great field on the other side. So, I mean, I'm really interested to see what you guys think who are, just past that hump and didn't.
We've made it.
Yeah, you made it. But it's something that I think we're going to keep seeing. It's hard when we're now an integrated residency taking, you're matching medical students and they're really young and they're trying to decide what they want to do for their whole career very early. And some who have only been on 1 or 2 IR rotations and now deciding their whole career. So I think it's probably normal for some people for the attrition rate to happen.
Yeah. I mean, I guess what I would say is my advice for medical students would be like, get as much IR in those last 2 years of your med school career as you possibly can to make sure that it's right for you, right? So I did 5 months of IR in my 4th year of med school, which obviously is a lot, but I basically gave up that little gap, that little like vacation that most 4th years take at the end so that I could really, figure out if this was for me or not early on. And then I kind of pushed off all my requirements towards the end of the year of my 4th year. So that's kind of my advice from the med school side. From the training standpoint, I think what I've noticed is like Nicole said, I think some people just aren't entirely sure what they're getting themselves into. And so, but then also like Nicole said, like there are so many great specialties within radiology. And right now the job market is such that you may even end up getting paid a little bit more to be a diagnostic radiologist with a different fellowship training. So than if you were to be an IR attending, and obviously the quality of life is, profile is very different for a radiologist. I will say at Jefferson, we have not had anybody leave our program except for one trainee whose company was acquired, and he started a company as a resident with his wife, and then part of the deal of the acquisition was that he had to stay on as CEO full time for 2 years, so he had to leave the training program. But other than that, we haven't had anybody else leave our program. And I think if I had to kind of like pinpoint our secret sauce, it is that we get our residents involved early on. They feel like they're part of the department, and then we don't really have a whole lot of vertical infrastructure. So you're taking independent IR call even as an IR1 at Jefferson with just an attending. So you're building those interpersonal relationships with the department very quickly. And you're also building like a sense of sort of responsibility, and, like that adds meaning to the work. And I think also kind of prevents those thoughts of like, oh, like, I don't even feel valued by this program. Like I'm not saying that that's necessarily what's happening, but I think that's probably part of it is like, trainees may not be feeling like they are qualified or valued. And to your point earlier, Nicole, like that idea of, that you're no different than a DR resident when you're rotating on IR because your skill set just isn't quite there yet. I think that can also be kind of demoralizing and lead people to kind of reconsider, like, why am I signing up for an objectively worse quality of life when there are other specialties within radiology that will, pay me more and let me, live a much more relaxed lifestyle with less call and less late hours and more shift work. That's kind of my take on it. Is I think a big part of it is just like involvement of residents early on and keeping them engaged. I think the focus for APDIR and for SIR should really be to kind of prioritize that early engagement of IR residents. And I think as we start moving to maybe more of like a surgical training perspective where we have more IR months in those early years, we may see a decrease in that attrition rate. I think part of it is also growing pains, right? Like this integrated program is so new. And I remember when I was matching into it, I felt like there was pressure to kind of, like if I didn't match into the integrated program, I would have to later on, down the line apply, and it would be a whole to do. And what we're finding is actually like now the independent IR fellowship is very non-competitive. I don't know how long it's going to stay that way, but it may make more sense for some trainees to kind of just take that path. I think if you're not sure as a trainee if the integrated path is right for you and you haven't fully confirmed for yourself that you want to be 100% in IR, then consider that independent pathway, which is frankly not competitive at all anymore. So there's like 2 spots for every 1 trainee that wants to apply for the independent pathway. So I think people will start to self-select more as that gets teased out.
Absolutely. And like both of you mentioned, I think especially if you're coming from a brutal intern year and you're going into diagnostics where the hour shift, the work-life balance kind of is complete opposite. There's often that way of thinking of like, hey, why am I going to go through this again? IR is in a way more related to a surgical specialty than a diagnostic when it comes to work-life balance. So I do agree with both of you that getting them on early, especially those early years, is extremely important. Residency is hard, but we're all a team. Rising tides lifts all boats. So you guys have any last minute pearls for our audience?
I think just for the students listening and the early residents, interventional radiology is a fantastic field. I have had no regrets. I can't imagine another field I would have done over this. So for those that are trying to decide, I think it's a great choice. And the best thing to do is, as Gregg alluded to, is to do rotations and to find mentors and other residents to ask for advice and to shadow. So get involved. It's a great field.
100% agree with what Nicole said. I guess what I'll say is, as the RFS annual meeting chair this past year, we did like a roundtable with chief residents and just kind of heard lots of the things that we talked about here. And I tried to echo some of those thoughts from all of those incoming chief residents it was both incoming chief residents and outgoing chief residents. And both had, thoughts that we tried to kind of echo in this episode. But I think what's happening right now in IR is it's still a very young residency program. And what we'll see is sort of fine tuning of some of these things over time. Obviously, there are regulatory boards to kind of please with many of these, changes to the rotations and to different requirements. And so that takes time, but then also feedback from senior trainees like us, I think is what's going to push this forward. So happy to chat with program leadership at any program and also happy to chat with any trainees. Feel free to reach out to me. I love hearing, differences in opinion. Neil and I often call each other on the phone and just wax poetic about what could be or what should be. So feel free to reach out.
Be positive and truck on. Guys, I want to thank both Nicole and Gregg for being part of the show today. I hope you guys got some great insight in how different programs are run throughout the country and ways that you can optimize your program back at home. Thank you.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _Backtable on Instagram, LinkedIn, X, TikTok, and Blue Sky. Backtable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Yannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.